Right. Hello, friends. Today I'll be talking on this topic, which is a debate which I had in Vizag. So my opponent was Dr. Subba Reddy. So the argument that I'll be doing is that early mobilization in ICU is not beneficial. So this is the debate that I'll be working on. So what is the agenda that I have for the debate? So I'll talk a bit on background as to what is the background of mobilizing patients early in ICU. And what is the hypothesis? So, what is the physiological rationale or clinical rationale as to how it is beneficial? We'll look into briefly in that. And we look into evidence which really substantiates my argument that early mobilization is not beneficial in ICU. And then we'll talk about a bit on what are the risks involved in mobilizing the patients early on, because that can lead to deleterious effects. So we need to look if there is some studies looking into the risk, and there are impediments or barriers in implementing this early mobilization as a process in ICU. Then we look into summary, and after this, obviously there'll be a rebuttal. So I'll just have 1 or 2 minutes on rebuttal. So this is the way I would approach this topic. So when we look at the background, so any ICU patients, if you imagine yourself dealing with ICU, they're all on monitor. They're connected to a lot of infusion pumps and they are on a ventilator. They may be connected to dialysis, so on and so forth. And many of these patients have life-threatening underlying conditions. And and many of the ICU patients, they would be trauma patients who have a lot of pain issues and who may have some drains, who may have undergone surgical procedures, and they would be in lot of pain and distress. And these patients, if we even remotely imagine to mobilize them, there would obviously, it is intuitive for us to believe that there is going to be increased risk in complications. And many of the ICU patients are confined to bed. And as I said, trauma patients, post-surgical patients, or any medical conditions, they may be in a lot of pain, especially someone who's on a ventilator and distress. So obviously, one of the quality marker is they need to be on some form of sedation and analgesia. And obviously, someone who is on analgesia and sedation, you wouldn't want to make them walk or do early mobilization. And they would be connected to a lot of infusion pumps. They will have IV access, so on and so forth. And when we intend to mobilize them or move them, there is always this potential hazard of these lines coming out and discontinuation. And someone on mechanical ventilation, obviously, there are risks in mobilizing as well. So these are some of the caveats that one should have in back of mind when even remotely you think of mobilizing patients in ICU. So now coming to what is the definition of early mobilization in ICU? Because if you look at the definition, I'm sure all my intensive care friends who are listening to this would dread whether is this something that is feasible and whether it is worthwhile putting patient to this sort of a procedure. So early mobilization is where you start some sort of a rehabilitative process early on and with lot more rigor and intensity. So the intensity of performing the rehabilitative processes or exercises is done with lot more intensity. But this is okay. We do it early, we do intensely, that is okay. But if you look the time frame, the definition of early mobilization, we start that in 2 to 5 days of someone in ICU. So that is something which is very worrying for us, isn't it? Because within 2 days, anyone who's on a ventilator or who's underlying sort of a clinical condition that has caused them to come to ICU may not have settled in 2 to 5, because average length of stay would be around 3 to 4 days. And in critically ill, this may be much longer. And thinking about mobilizing within 2 to 3 days or 4 days can be unrealistic. So definition itself, I believe, is a little flawed. And what does early mobilization? Not necessarily, because when you look at the definition, early mobilization in the mind, you think making patient walk. It is active range of movements, passive range of movements, making patients sit at the end of the bed and helping patients to stand and then gait sort of a training and walking with support. So these are the components which constitute early mobilization. So the definition is encompasses these dimensions early and intensifying the rehabilitative process within 2 to 5 days and it involves active range of movements, passive range of movements, and all these movements. So this is the definition. And what is the hypothesis? Why is it that there is so much of trials and studies which talk about early mobilization? So the background is, the hypothesis is, so early mobilization limits and prevents the dysfunction, mainly physical and cognitive dysfunction. So that is the hypothesis, that we mobilize patients early. It helps in limiting the physical and cognitive dysfunction. And it is also shown that early mobilization helps in your mucociliary dysfunction, which means it helps in facilitating the sputum clearance, and it helps to improve the muscle weakness. And it is also shown that early mobilization increases the alveolar tidal volume, helps in diffusion, and improves the ventilation perfusion mismatch. It is also shown on the cardiovascular function. There is some favorable effects of early mobilization. It improves the venous return into the heart. It improves the coronary perfusion. It is shown to improve the stroke volume and cardiac output. So these are all the hypotheses, hypothetical substantiation as to why early mobilization. Physiological models, it is shown that it has some favorable effects of this nature, and it improves the conscious level, and it is even shown early mobilization helps to improve the GFR. So these are all the hypotheses. Whether this hypothesis translates into clinical endpoint is what we need to see in the trial. So these are all the hypothetical thought processes that how early mobilization helps. So when you look at evidence as to whether early mobilization really helps, so there are three meta-analyses. There are 5 randomized controlled trials. Latest is in 2022, which I'll talk, and retrospective observational studies. So I've only picked up the studies since 2016. So because I really do not want to go back many years ago to see whether early mobilization. So this whole concept is a little newer one. So I've only looked at studies from 2016. So we'll go one by one. So this is the meta-analysis which came from Japan. So if you look at the title, it's early versus delayed mobilization for in-hospital mortality and health-related quality of life among critically ill patients, systematic review and meta-analysis. As you see, it's a negative study. They compared early mobilization versus delayed, and they found there's no difference in mortality and health-related quality of life in this meta-analysis. And if you look at this forest plot, 7 studies, as you see, there is no signal towards favorable benefit with early mobilization. And as you see, the P is not significant. So this was a Japanese study. And then came this Chinese study in 2019. Again, a meta-analysis, early mobilization of critically ill patients in the intensive care unit. This included much larger, because you saw the Japan that looked 7 trials. Here they looked at 23 randomized controlled trials, 2,308 patients. Here they looked at early mobilization versus delayed. And what they shown was that early mobilization, in fact, they showed trend towards increase in 28-day mortality and ICU and length of stay. So which is the mortality in the ICU and the hospital mortality, there was signal towards higher risk, and there was increase in the adverse event as well, but did not attain statistical significance. So although there was signals pointing towards greater mortality, they did not attain statistical significance. So that is the Chinese study. Then there was this Australian study, again a meta-analysis, the effect of active mobilization and rehabilitation on mortality and function. So this came from Australia. Again, as you see, it's a negative study. 14 studies they took, 1,753 patients, and they looked at mortality at ICU discharge and hospital discharge. As you see the forest plot, so P is 0.18, and you see the diamond not favoring early rehabilitation. So this is the forest part looking at the hospital mortality at hospital discharge. Again, you see P is 0.76, and the diamond is not moved towards early rehabilitation or favoring early rehabilitation or vice versa. So these are the 3 meta-analysis, one from Japan, one from China, and one from Australia. All 3 taking all the randomized control trials, up to 14 randomized control trials by Australians, 23 by Chinese, and 7 by Japanese, all showing no benefit of early mobilizations in this meta-analysis. So now we'll slowly move to randomized control trials. So this study basically said no impact on short-term and long-term mortality. And they even look at whether it had effect on quality of life, function, ICU length of stay, hospital length of stay, and duration of mechanical. So there was no effects in this, because this meta-analysis looked at other endpoints as well. Then we'll slowly move to the randomized control trial. So this was a randomized control trial which came from Iceland. So effect of intensive upright mobilization on outcome of mechanically ventilated patients in the ICU, a randomized control trial with 12-month follow-up, came from Iceland as late as 2021. So here they took mechanically ventilated patients, small study, and these were mechanically ventilated patients whom they did active mobilization or early mobilization. So here, as you see, they did mobilization twice a day. This is an intensive group, and this is the less intensive group where they did once a day. They looked at short-term and long-term outcome, and as you see, there's no difference between early the intensive mobilization versus non-intensive. And at the end of 1 year, to the discharge, they looked at health related quality of life and your exercising ability. And even that, they did not find any difference between intensive mobilization and non-intensive mobilization. So even at the end of 1 year post discharge, health related quality of life and your exercise capacity was no different in the group which was intensely mobilized versus non-intensely mobilized group. After this, then this was another randomized control trial that came in 2018 by UK, intensive versus non-intensive therapy versus standard physical rehabilitation therapy in critically ill. It's called EPICC study, multi-center parallel group randomized control trial. It came in thorax. So here again, they took mechanically. So this is a larger study than Iceland. They took 308 patients who were mechanically ventilated and followed them up for 34 months. So the intervention group had 150 patients who underwent intensive rehabilitation, and control group had 158. What intensive rehabilitation is? They did this rehabilitative or early mobilization maneuvers for 90 minutes in a day, and the control group received for around 30 minutes per day. So there was around 60 minutes more rigorous sort of a exercise that happened in this intensive group. And they looked at physical outcome. There was no difference between the intervention and control group. So basically, we had a RCT that coming from Japan, from Iceland, and from UK, showing there is no difference in mechanically ventilated patients. Then, not necessarily for everyone that we can do this physical exercise. Then there was a thought process that there is a concept of newer techniques called early muscle stimulation. So the effectiveness of newer techniques is where you use electrodes to keep stimulating the muscle. So electrical muscle stimulation, which we call as EMS, was adopted. So in EMS, they put this triboelectric nano generator and they put an electrode on the muscle and they keep stimulating the muscle. And this is more like a, which is called as EMS. And these are the newer techniques which also come under the ambit of early mobilization, where one of the techniques to do early sort of a rehabilitative. And this is shown to reverse the muscle weakness, improve the perfusion or the blood flow to the muscles, and improve the atrophy. So this is the hypothesis in adopting this newer technique. The reason we are talking is there are trials done with this also in an intensive way to see whether this is going to help. So this was a trial that came from Switzerland and Austrian group. As you see, muscle mass, strength and functional outcomes in critically ill patients after cardiothoracic surgery. Does neuromuscular electrical stimulation help? So this was the Catastim 2 randomized controlled trial. As you see, the thumbs is going down, so it's a negative trial. So the primary outcome in this particular study was to look at the muscle thickness by ultrasound after doing electrical muscle stimulation. So they looked at the strength of the muscle by the Medical Research Council score, it's MRC score, and they did an ultrasound to measure the thickness of the muscle, whether the thickness of the muscle improved with electrical muscle stimulation. So electrical muscle stimulation in this study was done for the quadriceps muscle and then evaluated. And they did this EMS or electrical muscle stimulation of the quadriceps muscle from the first post-operative day until discharge to 14 days. So this is how they did it. And they had 54 patients and they had intervention group and control group. And as you see, they measured the muscle thickness by ultrasound and there was no difference between the intervention group and the control group. And the strength, when they assessed the strength by Medical Research Council score, so they found that there was 4.5 times faster improvement in the strength in the intervention. So that is one positivity they found in this, but the muscle thickness really did not improve. Then this was another trial which came from France. This was published in JAMA in 2018. Effect of in-bed leg cycling, which we call as cycle ergometry, where patient is sleeping on the bed and doing the exercise on the cycling pedals. And along with it, there is electrical stimulation of the quadriceps on global muscle strength in critically ill adults. As you see, just figuratively I put, so patient is sleeping on the bed and he'll be cycling with a pulley that is put on the edge of the bed, and these are available and people have done trials because this is the easiest way of early mobilization in ICU, where patient is sleeping on a ventilator and they keep doing pedaling on the cycle. This is called cycle ergometry. So this was a single center randomized controlled trial. It's a reasonably big study, 312 patients, 159 who did ergometry, which is a cycle ergometry with electrical muscle stimulation, and 153 in the standard group. Then again, they looked at median Medical Research Council score, which is the muscle strength assessment. And as you see, the score was no different. There was no significant difference between the group which did cycle ergometry and EMS versus standard. They looked at ICU mobility scale. Even that, there was no difference between the intensive exercise and the usual care group. And they looked at ventilatory free days at day 28. And as you see, there was no difference between the ergometry group and the standard group. And they looked at outcome at the end of 6 months. Again, there was no difference between the cycle ergometry and the standard. So this is a very good study from France where they did intensive exercise and in a good number of patients, but they did not find any difference, be it with the muscle strength, be it with the mobility, be it on the core ICU endpoints like ventilatory free days or outcome. There was no difference. So this is another study. So those are the three to four randomized control trials we spoke about, where really early mobilization techniques in whatever format we use, mechanical ventilated patients, make them walk, or even muscle stimulation you do, or cycle ergometry you do. None of them have really found to have had any impact on improving the outcomes, be it from the physical strength, mobility aspect, and the ICU core endpoints as well. So now let us look into this retrospective observational study, which was published in Journal of Clinical Medicine from Japan, which purely looks at the what are the risks associated with this early mobilization. So the title of this is Risk Factors of Patient-Related Safety, because what is terribly important for us is how safe it is for us to make the patients do early mobilization, especially when they're unwell and when they're on ventilator. And this is what this paper looked at for risk factors of patient-related safety events during active mobilization for intubated patients in intensive care units, a multi-center retrospective observational study. So, as the name sounds, it's a retrospective study. Here they looked at 2000, they evaluated 2013 patients who were on ventilator between Jan 2017 to 18, and they could identify only 87 patients out of 2013 who were actively mobilized. And they looked at PSC's patient-specific events happened in 11.5% of these patients who were actively mobilized. And they looked at the cumulative sessions these patients have had who were early mobilized, and they evaluated 198 sessions. And patient-specific events happened in 6.6%. And the type of events they had was the blood pressure instability happened at 40.4 events per 1,000 sessions. When you take 1,000 sessions, 40.4 had blood pressure instability. Heart rate instability happened in 15.2 per 1,000 sessions. And desaturation happened in 10.1 in 1,000 sessions. Small group of patients which were picked up who were actively mobilized, and they evaluated 198 sessions, and this was the event rate that they found. None of them had falls or tube removals or no life-threatening events. And when they looked at uh, the type of events that happened with different exercises. So for standing, the highest event rate was with standing exercise. They had 205 per 1,000 sessions. Means the events were much higher with standing, and for sitting, it was 26.1 per 1,000 sessions. And when they did gait training, that was the second, 166.7 was the event rate per 1,000 sessions. It means, so when we are making patients stand, I think the risk of them having events is much higher, followed by walking, and sitting is less events. So this is the sort of findings in this retrospective study. So there are so one needs to understand. So one thing is we saw three meta-analyses around four randomized control trials, which basically said early mobilization is useless. But what we need to understand is what are the logistics involved. So there is increased time that nurses have to put their effort and energy and time when we are actively mobilizing, because every listener would know that one physiotherapist may not be enough to mobilize one patient. You need at least two, three people. And in the era where patients are getting more obese, we need more people to mobilize. So it involves, it is a resource burdening, and it involves a lot of time that nurses have to expend in mobilizing, and even the safety of personnel involved in mobilizing, especially when there is an obese individual or even any individual who is connected to a lot of things, mobilizing them incurs some safety issues as well. And all this has a bearing on the cost to the patients, because you need to have more physiotherapy people, engaging more nurses and more paramedical people to mobilize, which all incurs cost to the organization and to the patient as well. And adequate number of staffing should be there, which is always a struggle in our ICUs, and this also can be problematic. And there has to be a excellent and extensive coordination between various teams in coordinating this mobilization, which is also a logistic challenge. And most importantly, in our zeal and effort to do early mobilization, we may be causing a lot of discomfort to the patient and a lot of pain to the patient. So these are some of the impediments or barriers that intensivists should bear in mind when we are overzealously looking at doing early mobilization. So the summary of my contrarian view as to why early mobilization is useless is, for me, the whole definition is flawed, because just imagine mobilizing some ARDS patient who is on a ventilator like this within 2 to 5 days. I believe that whole definition itself is flawed. And any sick patient, the last thing that we would have in mind is to keep mobilizing, especially when your hemodynamics have not settled, your respiratory parameters have not settled, or your neurological status has not stabilized. So we cannot really comprehend thinking of mobilizing this patient. And look at the core evidence. When you look at three meta-analyses, five randomized controlled trials, none of them substantiate us doing this early mobilization. And retrospective observational studies clearly shown all the risks that are involved, especially in making patients stand. So there are definitive sort of events that tend to happen, like desaturation, blood pressure fluctuation, or they can go into AF, so on and so forth. So basically, the evidence do not justify or substantiate early mobilization, and it is a good hypothesis generating subject, but it does not have any clinical validity at this point of time. And to add to this, there are a lot of logistic barriers with regards to the adequacy of the nursing staff, and with regards to the costing, and with regards to excellent coordination that needs to happen. And it is a resource burdening sort of a situation, and it is non-practical at this point of time for implementation, because the risks significantly outweigh the benefits. So this is my argument as to why early mobilization is something that we should not adopt as a standard of care. So these are my arguments against Dr. Subbareddy. So obviously he will present his stand. So my rebuttal will be with the most latest study and with the practice changing study that came as late as 2022 in NEJM. And I think this possibly puts a nail on the coffin. So which came from the Australian group by the team study investigators, early active mobilization during mechanical ventilation and ICU. So this randomized control trial possibly should put an end to any debate on early mobilization in ICU. And this is the largest study. As you saw, the previous studies had around 300 odd patients. So these had 750 mechanically ventilated patients, 371 randomized to early mobilization and 370 to the usual. And the primary outcome was to look at patients who got alive and who went out of hospital. And as you see, there was no difference. So who got alive and went out of hospital were 143 in early mobilization, 145 in usual care, non-significant. and they looked at 180-day mortality. Again, no difference between early mobilization and the usual care. But most importantly, what this highlights is re-emphasis of the retrospective observational study, which showed that event rates tend to happen in early mobilization. They looked at adverse events in this group. As you see, it was 9.2% in the early mobilization, 4.1, and that attained statistical significance. So the adverse events were significantly higher in your overzealous attempt to mobilize these patients early. They looked at a lot of secondary endpoints like quality of life, disability, cognitive and psychological function. There was no difference between early mobilization and usual care. So the conclusions that was made in this landmark paper is increase in the early active mobilization did not lead to patients getting alive and getting out of hospital, and it was associated or it was brought upon with more increasing in the adverse events. So I would end my debate with saying, so this is the sort of adverse events that they had: blood pressure alteration, cardiac arrhythmias, they had more, and desaturation, they had more. So I would end with this sort of a analogy, like your overzealous involvement with early rehabilitation leads to slips, trips, and falls. So patients would slip from the recovery process, I would trip to getting more critical, and possibly will fall to death. So that would be my conclusion of this debate. Thank you, one and all. So you can visit my website www.drpradeeprangappa.com to rehear to this lecture. So thank you, one and all.